So glaucoma examination depends upon the corneal properties, and as the refractive surgery is growing in the past 2 decades, so the altered corneal mechanics lead to a reshaped cornea post-refractive surgery, which poses a challenge in diagnosis, follow-up, and management of glaucoma patient. These patients will require both cataract extraction and glaucoma follow-up in future. So the pre-operative assessment has already been discussed by my colleagues, is very important. Looking for the family history, first degree relative, ocular hypertension, high myopia, tilted disc, vertical cup disc ratio, the central corneal thickness, the presence of any pseudo exfoliation or pigment dispersion is important in assessing the patients undergoing refractive surgery. The risk of developing glaucoma, the pre-existing glaucomatous damage, the presence of the pre-operative visual fields are important in assessing in the patients undergoing refractive surgery. Patients which have high pattern standard deviation have a greater chance of developing glaucoma even in the absence of visual field scotomas. It's important to run OCT, RNFL, and the glaucoma investigations available pre-operatively, because this will help in comparing it with the future measurements. The disadvantage is that the database available for these investigations include only a limited number of patients with unusual disc, and these are excluded. So digital photographing and red-free imaging of the optic disc and the comparison with future photos give valuable information about the changes of both the optic nerve and the retinal nerve fibers. The intraoperative risk factors, as has been discussed by Dr. Tulika, that there is a transient IOP rise, but it usually does not affect the optic nerve unless it is prior compromised. The effect of corneal thickness is that the myopic ablation causes larger underestimation of IOP as compared to the hypermetropic. Both PRK and LASIK can cause a reduction of post-operative IOP, and deeper the ablation, the higher the pre-operative IOP, the more is the post-operative reduction. The post-operative reduction of the IOP is due to the thinning of the corneal stroma and change in the corneal curvature, the instability of the corneal flap, and the removal of the Bowman's membrane. So the formulas which have been given to give the corrected IOP has already been discussed by Dr. Garvita. There are various devices available to measure the IOP, that is the pneumatometer, the tonopen, the Pascal dynamic contour tonometer, and a brief discussion was given in the previous presentation. The effect of the corneal viscoelastic properties.
Please conclude.
Conclusion?
Conclude.
Okay. So since we are running short of time, just to conclude that raised IOP management is a challenging task in patients who have undergone refractive surgery due to altered corneal biomechanics. Thorough preoperative evaluation of the risk factors should be ruled out and thoroughly discussed with the patient before taking up the patient. High degree of suspicion, early detection, and correct IOP measuring device is imperative in tackling the situation. Thank you.